The patient presented missing tooth number 19. You can see the typical saddle-shaped defect of the ridge that occurs when the tooth has been missing for some time. After reviewing the prosthetic option, an implant-supported crown was selected as the treatment of choice. To accurately locate the mandibular canal as well as visualize the extent of the buccal defect and precisely place the implant, the decision was made to utilize digital treatment planning and guided surgery. Since Nobel Replace was the implant of choice, the case was planned following the Nobel Guide protocol. At the initial exam, upper and lower impressions and a bite registration were made and sent to the lab, where a radiographic guide and radiographic index were fabricated on articulated study models. An accurate radiographic guide is critical to the success of guided cases, as it shows the ideal position of the tooth or teeth to be replaced. With Nobel Guide, the scan of the radiographic guide is what is utilized to fabricate the surgical template. The radiographic index is a bite registration that is used to ensure the radiographic guide remains completely seated during the CT scan. Per Nobel Guide protocol, the patient was sent out for a dual CT scan. The first scan is the patient with the radiographic guide and radiographic index in place. The second scan is the radiographic guide alone. The DICOM files of the two scans were then uploaded and sent to Glidewell through their secure online portal. Through Glidewell's digital treatment planning services, the case is virtually planned. Here you can see the Nobel Guide planning software. The left side is a three-dimensional rendering of the patient's jaw. The mandibular canal has been located and a 5.0 by 10 millimeter implant virtually placed. The right side of the screen is a cross-section through the intended implant site. You can also see the outline of the crown for number 19. One of the advantages of the three-dimensional image is that you can see the extent of the buccal defect. The planning software allows you to add and take away various images. On this screen, the bone and radiographic guide were removed, providing a clear visualization of the proximity of the mandibular canal and the implant. The yellow halo around the implant is 1.5 millimeters, which can be used as a measurement aid. In this case, we had good ridge height, allowing a large margin of safety from the canal. The panoramic image shows adequate spacing from the adjacent roots. This final screenshot shows the trajectory of the implant through the occlusal table. Digital treatment planning allows you to ideally plan the case from both the surgical and prosthetic perspectives. Since this was a single tooth replacement, no anchor pins were planned. Once I have approved the plan by going to my online account, the surgical template is ordered. In partially edentulous cases, the surgical template often requires adjustment. This adjustment will be handled by Glidewell Laboratories. If necessary, the flange area can be modified if it interferes with reflection of the flap. A pre-op scrub with Paradex is recommended to reduce the oral flora. I feel it's very important that a sterile technique be used in all implant surgeries. A full thickness flap is elevated utilizing a Bard Parker. In many instances, it would be advantageous to use a CO2 laser. In addition to elevating the palatal flap, it is also prudent to, on a limited basis, elevate the lingual portion. Will make the suturing, when the case is complete, much easier than if the lingual tissue is still adhering to the bone. We can now see the deficient area in the labial plate. However, as we noted on the CT scan in our digital treatment planning, this ridge is still has adequate width for a 5.0 diameter implant. Since we already laid a flap, the 2.0 millimeter twist drill was utilized first rather than the start drill. The 2.0 millimeter drill guide seats into the surgical template sleeve. A depth stop was set on the twist drill at 10 millimeters. It should be noted that the guide drills are longer than the standard drills. It's very important that the patient's vertical opening is evaluated at the initial exam. The drilling sequence continues with the 3.5 by 8 millimeter drill, followed by the 3.5 by 10, followed by the 4.3 by 10, and finally the 5.0 by 10 millimeter drill with the corresponding drill guides. Each of these tapered drills has a built-in depth stop. And then using very low revolutions, the implant is brought to place. In this instance, we could have placed the implant through the surgical guide, but in this case, with an open flap procedure, I could readily visualize the placement of the implant, and just for expediency's sake, did not use the guide. Utilizing the torque wrench for final seating will provide better control as well as provide feedback on the primary stability of the implant. The torque should not exceed the implant manufacturer's recommendation. One of the divots on the guided implant mount should face to the buckle. This ensures that the internal abutment connection is in the proper rotational orientation. After placing the freeze-dried demineralized bone putty, we then use the sandwich technique and place the calcium sulfate /HTR/PRP mix over the bone putty. With the calcium sulfate in the mix, it will gradually harden and become a protective barrier against fibroblast ingrowth into the bone graft material. A contoured healing abutment, in this case a 3 millimeter in height by 5 millimeter width, is placed. This serves the purpose of forming the emergence profile during healing. Sometimes, with the presence of blood and over-tightening the abutment, it can become severely locked into the implant and create some great anxiety when you're trying to remove it at a later date. Suturing is completed utilizing a 4.0 chromic suture. The use of the 4.0 chromic is good for 5 to 7 days. Sometimes in some mouths it will go even longer. And it will eliminate the need for suture removal at a later date, which can be uncomfortable for the patient and time-consuming for the dentist. This case could have been immediate loaded due to the dense bone and very good stability, but I opted not to immediate load the case due to the grafting which was being placed, and we might get better healing without the immediate load. This is a view of the site at 2 weeks post-op. Notice the rapid healing and lack of inflammation in the area. Following a healing period of approximately 3 to 4 months, an implant level impression and bite registration were made. These were sent to the laboratory with the opposing model. The master cast was then fabricated and optically scanned. For strength purposes, I requested a custom titanium abutment and a porcelain fused to metal crown. Glidewell can provide a custom abutment at about the same price as you would pay for an off-the-shelf abutment from the implant manufacturers. Here you can see the 3-shape abutment designer program being utilized to virtually create the custom abutment. This software allows the technician to correct angles, adjust the overall height, as well as set the margin below the gingival contours. Once the design is completed, the custom abutment is milled and the PFM restoration fabricated. So at 12 weeks we are now ready to deliver the abutment and crown. After removing the healing abutment and irrigating the screw access hole, abutment is fitted to place and the screw is then tightened. Adjusting the occlusion, a very important point is to be considered. We wish to have the implant supported prosthesis slightly out of occlusion from the natural teeth. because as shown by Dr. Carl Misch and many others, natural teeth will depress anywhere from 50 to 75 microns. If this is the case, when the natural teeth depress under chewing forces, then that would make the implant-supported prosthesis supraocclusal, which will lead to traumatic occlusion and possibly vertical bone loss. One of my preferred ways of checking this is for the natural dentition to be holding firmly a 7,000 shim stock, while the 7,000 shim stock will slide freely over the occlusal surface of the implant when everything else is in total contact. The abutment screw should be tightened to the manufacturer's recommended torque value, in this case 35 Newton centimeters. To compensate for relaxation of the screw threads, wait 5 to 10 minutes and torque the screw once again. The cotton pellet is covered and the screw access opening sealed. And then the crown is cemented using a thin, minimal application of, in this case, Improv, which proves to be an adequate permanent/temporary cement. In most instances, if it's necessary to remove the crown, one can do so without damaging the porcelain or the underlying abutment. Yet, under normal circumstances, the crown will not come loose in normal function. It is critical that all excess cement be removed. This case demonstrates several new technologies available through Glidewell Laboratories, including digital treatment planning and CAD/CAM custom abutment design and fabrication. It also illustrated that guided surgery is not synonymous with flapless. When it is appropriate, ancillary procedures such as grafting can be easily accomplished in conjunction with guided implant placement. These new technologies can help your cases proceed smoothly and predictably, ensuring patient satisfaction and long-term success.